Hello, my name is Robert Vragovski. I'm an orthopaedic cast technician at Royal Melbourne Hospital. I've been casting for over 20 years. This is a presentation of fracture management of common casts. So starting with the first slide, common cast. We have below elbow, scaphoid and thumb spica cast. So we sometimes call it scaphoid, sometimes we call it thumb spica, depending on where you work at which hospital. The other one is very common too, is the below knee cast. So these are the main common casts that we tend to cast a fair bit. Moving to the next slide, before we actually start casting, there's 4 casting objectives which we follow. It's position, integrity, fit and function. So the first one, position. First thing we look at is fracture alignment, making sure the fracture is aligned in a perfect position before we actually place the cast. Also the joint position is very important. Also lib alignment. If you don't have any of these, once you put the cast on and you put it in position afterwards, you're going to get creases and wrinkles in the cast. So when you're having these wrinkles, it's going to cause pressure areas and you're going to have all sorts of problems. So that's position. So position is very important right from the start. Also, you need to have parameters. When you apply the cast, you're going to make sure you have your set parameters where to go to, and you don't want to go over these parameters. So that's position, integrity, which is the next one, which is obviously the skin. Make sure the skin is in good condition. Obviously you can see the picture down below how it's got a fracture blister, so you need to treat that or put a dressing on it before you actually put the cast. Also made of the correct material, so you need to choose what material to use. So whether it might be a fiberglass, polyester or POP. The other thing too is integrity, is make it strong enough. So if they're weight bearing on the cast, sometimes you might need to use crutches or different types of frames. So you need to choose the correct material to put the correct on the correct fracture and also the correct immobilization. So cast, also you need to tailor make it to the individual patient. So basically some patients have got deformities and you might have to correct it in a special way to fit it or make it stronger or not as strong. So the next slide, the fit. So you got position, integrity, fit. You got to make sure it's not too tight or not too loose. If it's too tight, obviously they're going to have problems, circulations. If it's too loose, it's not actually holding the fracture. The other thing too is make sure it conforms anatomically to the shape of the limb. If you don't shape it to the limb, obviously it's going to be loose, it's not going to work. The other thing too is molding it. When you mold a fracture, you've got to make sure you mold it in the correct position and make sure it's molded really well. Bony prominences, make sure you protect the bony prominences by putting extra padding where you need it. And also you've got to look at no obvious defects. So if you look at the picture down below, you can actually see that's a short arm cast. And you can see the way it's done. It's gone over certain joints, what doesn't need to be immobilized, where it's not functional. So that's the fit. The next step is function. All unaffected joints are free to move, so you don't want to immobilize anything. Cast is not excessively heavy, so if you make a heavy cast, obviously it's going to cause a lot of problems, especially to the elderly. So when you put a plaster on or a synthetic, if you put too much layers or too much rolls, it'll be really heavy. You can actually even dislocate a shoulder or anything like that, depending on what you're trying to immobilize. Also, patient is aware of any restriction of use. So you're going to make sure you explain to the patient what they can do, what they can't do. Also, the exercise. Exercise, you need to explain to them what they're capable of doing with that cast when the cast is on and what they can't do. We also give them verbal and written instructions. So you've got position, integrity, fit and function. The next slide is the types of materials that we use. We tend to use POP, which is plaster of Paris, also fiberglass, polyester and semi-rigid soft cast. So these are the most common ones that we tend to use. There's other materials that we use. These are the ones, polyester we tend to use a lot more than anything else. So the next slide shows a colles fracture, where you can actually see on the first diagram where they've fallen on an outstretched hand, the distal end of the radius displays dorsally. So with the other picture, you can actually see where it's corrected and the position's in the right position anatomically. and it's an acceptable position with the cast on. So that's a colles fracture. Usually with colles, you're falling an outstretched hand. They call it fouche or the dinner fork deformity. Next slide is the materials that we use to put a short arm or a below elbow cast. So you can see on the picture there, you've got tech form, which is a 3-inch or 7.5 centimetre. You've got your undercast padding. Also, you've got your thumb piece and stockinette when to put it onto the limb. Also, you need in that picture, which is missing, is your gloves. Obviously, if you don't have gloves and you're using synthetics, you surely find out you're going to have pink hands, or you might have black hands, and it'll take about a week to get that stuff off. So you learn really quickly with synthetics, you do need to use gloves. With POP, you don't have to, but it's up to you whether you want to use it or not. So that's your materials for a below elbow cast. Now, a below elbow cast or colles cast should look like this. Now, there's a lot of interpretations with colles cast. Some people put the palm flexed right down. Some people put it mid. Some people even put it in neutral. We tend to, for a colles cast, and traditionally is slightly palm. If the distal radius is shorter, they're sometimes ulnar deviated. So you can actually see on the picture there, where it's 2 fingers from the antecubital fossa, hasn't gone past the EMP heads, and the thumb is quite free. So it's a functional cast, but it's slightly bent, so the fracture can actually heal in that position. Once it's healed, it comes out, and then they put something else on, which is a wrist brace or things like that. So that's a colles cast. So these are different views of a colles cast. So you can see from the AP and from the ulnar side, from the lateral. So you can see we haven't covered anything. It's functional. The top, you can move the fingers freely, and on the bottom picture, hasn't gone past the fifth, past the MPs. That's a colles cast. Next cast, which is a normal below elbow or a short arm, that some people might call it, you can actually see the hand, it's in neutral. Some people call it neutral. Some people call, everyone calls neutral a different way. Some people have the wrist dorsiflexed about 15 or 20. Some people leave it where it's more comfortable. So my neutral is this on the picture, where the patient is comfortable with it. And you can actually see on the right, the far right, where the thumb is not immobilized, and it's 2 fingers from the antecubital fossa, and it's in straight position. And the middle picture, so this is how my below elbow cast looks like when I finished with it. And you can see it's different colors. That Össur tech form deliver different types of colors, so you can get a rainbow pack and all sorts of colors. So that's a below elbow. Next slide, we've got a Smith's fracture. Again, another short arm cast. Smith's fracture is opposite of colles, which is falling backwards with the back of the hand, not forward like the colles. So they call it a Smith's fracture. You can see on the pictures, it's going volally. It's not dorsally displaced, it's volally displaced. So to correct that, we tend to do the opposite of colles, which we supinate it, and you can see the next slide where you've got the cast in supination and dorsiflex the wrist about 30, as much as we can get it, not too much, otherwise you're going to have problems with rehab afterwards. So you supinate it, and you can actually see the parameters are the same again. The materials that we use are the same. We use 1 roll, undercast padding, and stockinette. And again, the parameters stay the same. It's just the arm is supinated, not prone like colles. So that's the next slide. Will show you a few different views. You can actually see from the lateral and the AP. So you can see it goes up to the distal palmar crease, exactly the same as a colles, but opposite. Then afterwards, when the cast comes off, sometimes we tend to put them in a wrist brace. So this is a wrist brace from Össur. There's all different types of wrist braces, but I found this a little bit more comfortable because you can look at the straps. It's got 4 straps, and it is a bit longer than normal braces. So it's quite comfortable. Sometimes patients prefer to have this after a cast because obviously they've had muscle wastage and they don't want to sort of feel vulnerable, so they want some sort of protection, or they might need it for another 2 weeks just to protect it so they don't do any activities. So again, we sometimes put this on depending on the referral by the surgeon or what's required, or sometimes it hasn't quite healed quite right. They might leave it for another week or 2. It's just a good way of supporting. Now, some fractures, yes, If it's a simple fracture, they might turn around and just put it in a wrist brace right from the start, where there's no casting required. But it has to be a simple, like a buckle fracture, something really simple that's not going to move or displace. So they might put it into a wrist brace. So that's your short arm below elbow cast, and with a wrist brace at the end. Next cast is a scaphoid, which we commonly do at work. So scaphoid position is very important. Again, our 4 basic steps: position, integrity, fit, and function. So with a scaphoid, as you can see on the photo, the thumb should be aligned with the radius. Wrist should be dorsiflexed approximately about 15 to 30 degrees, depending on. But if you align the thumb with the radius, you should be able to get that 15, 20 degrees. Automatically, the wrist comes back. That's a functional cast. You should be able to oppose the first digit, not the middle finger, but the first digit, so you can oppose it. And you can see the parameters, which I'll show you in the next slide. 2 fingers from the antecubital fossa and up to the distal palmar crease, shy of the MP heads, and just below the IP joint. Now, we don't go right up to the IP joint because it will restrict it. So we just go just below the IP joint so you can actually move it. That's a functional cast. Again, following your 4 basic objectives: position, integrity, fit, and function. So the next slide is you can actually see on the lateral how it fits, and making sure that the wrist is not ulnar deviated. You need to keep it in neutral position and straight. And again, 2 fingers from the antecubital fossa up to the below the IP joint and distal palmar crease. And you can see both sides on the picture. Afterwards, with the scaphoid, we generally, with all fractures, we tend to keep them 4 to 6 weeks, again, depending on the fracture. Sometimes scaphoids, they depends on where you work. Some places like to keep them 6 weeks. Some places they like to keep them for 8 weeks. Again, some places like to keep them for 12 weeks in a cast. Again, it all depends on the hospital that you work in and what's referred by your orthopaedic surgeon. And they've all got different ideas and different opinions, and there's not one of them is wrong. Now, as you saw in the previous slides, we included the thumb. Now, I know there is a study done that you don't have to include the thumb, but that's a study that's been done, and some orthopedic surgeons tend to not include the thumb. Now, that's really entirely up to you and up to the doctor to refer you whether they include the thumb or not. Once again, after that has come, sometimes after 8 to 12 weeks, scaphoid can come off, and they might do a NORF, or they might actually put them in a scaphoid brace, as you can see on the picture here. Now, again, the scaphoid, depending on the fracture, where it's located in the scaphoid, whether it's through the waist or distal pole or proximal pole, you might need to keep it a little bit longer. That all depends, again, on the fracture too. So afterwards, you might need to put them in a scaphoid brace. So that's your scaphoid. The materials that you'll use, again, 1 3-inch casting material, padding 3-inch, stockinette. Going on to the next, the ankle fractures. The most common ankle fractures are the Weber classification that we tend to follow. Again, there is more classifications after this. You got the Weber, which is Weber A, B, and C. So you can see on the picture down the bottom, Weber A, Weber B, Weber C. So again, with the X-rays, a Weber A, you can see it down below. With a Weber A, sometimes they put them in a cast. Generally these days, they put them in a cam walker. Again, it all depends on the fracture and whether the talus has moved or not. Again, the orthopedic surgeon will make that decision. He will let you know whether you need to put them in a cast or in a cam walker. Again, some of them don't even put them in a cast or a cam walker. Again, it all depends on the fracture and where it is and how much it's fractured, whether there's a gap or it's displaced or anything like that. So Weber A, commonly, again, cam walker. That's how they treat it here where I work. Again, it could differ from place to place. Weber A, now we've got Weber B and Weber C. So you can see Weber B, it's up high, and you can actually see on the films on Weber B, the talus has actually shifted across laterally and it's displaced. So generally with these type of fractures, they prefer to ORIF, and you can see actually on the picture where they've put a plate. Sometimes they put a diastasis screw right across, but again, that's up to the surgeon to decide that. With Weber B, we've noticed the trend now these days. If it's not displaced the talus, they sometimes put them in a cam walker again. Again, it all depends on the surgeon. Here, we tend to sometimes put them in a cast for a couple of weeks till everything settles, and then take the cast off and put them in a cam walker. But again, it differs from surgeon to surgeon, the treatment. Weber C fractures, they always tend to operate on it, and it's a bit higher, as you can see on the fibula. Usually they tend to operate always on these. It's very rare they'll just leave them as is. Again, with these ones, you definitely put them after they're off it. They usually put them in a cast. Sometimes they put them in a cam walker because they've got a plate. It's supposed to be sturdy and strong. Materials used for a BK cast, usually we use 2/4 inch or 2/4 10 centimeters and a 3-inch or a 7.5 centimeter. So as you can see on the picture, 3 rolls all up for a below knee padding, about 2 to 3 layers, or 2 to 3 rolls. Generally when we cast them, we always put minimum 2 layers and max 3. If there's any bone prominences, we put a little bit extra where we need it. And you also got your stockinette. So first goes on the stockinette, then the padding, then the casting material. So don't get it confused. Don't put the casting material, then afterwards the padding, because we have come across some casts where they put POP first and then padding over the top, which, yeah, is a shock, and it is unusual, but it has happened, and I've got pictures to prove that. They're not on here. So again, once again, on the photo, you can see there is no gloves. You do need gloves. I totally forgot to put the gloves in the picture. So sorry about that. I thought it's just a general thing that people would know and have common sense to put gloves before they touch synthetics. If you forget, you'll work it out and you'll never do it again. Okay, so they're the materials for BK. Now below knee cast, as you can see on the pictures, the parameters are, again, 3 fingers from the popliteal fossa, up high, up on the metatarsals. Now, that's a common below knee cast for any ankle fractures. Now, if you've got metatarsal fractures, obviously then you need to go past the toes and include the toes. Now, there are some hospitals that include the toes all the time, and on the anterior they keep it open. Again, it all depends on your hospital where you work. Now, generally, what we need to look out, if you can see on the bottom one, you're going to make sure you don't put too much pressure on the head of the fibula, because if you put too much pressure on the head of the fibula, you've got the peroneal nerve that's wrapped around, you can get a foot drop. So always be mindful. 3 fingers underneath the popliteal fossa should clear that. But again, just be mindful of the head of the fibula. And again, obviously the skin integrity, the position of the limb, you need to make sure it's at 90. The only time that we would put a cast on in plantar flexion or in equinus would be for Achilles tendon. Again, it's not for a fracture, it's for a tendon, but that's the position that we put it. The rest usually should be always at 90. Again, unless you've got a tendon and a calc fracture, then you'd put it mid. Again, it all varies. So there's different fractures, different positions. So very important, the position right from the start. So when you're casting, if you don't keep it at 90 and maintain that position, you will get wrinkles on the anterior because you're trying to push it and get 90. So always maintain position, the integrity. How thick do you make it? I just said 3 rolls. That's for a non-weight bearing cast. But if it's weight bearing, you can always put a back slab at the back of it to make it stronger. And generally, we look at the patient. Now, obviously, if it's a fairly large patient, you want to make it a little bit stronger, then go a little bit weaker. So always err on to a little bit more than a little bit less, but making sure you put the correct materials, stockinette, padding, then your synthetic material or your POP, depending on choice of material, what you're using at the time. So that's your below knee cast. So if you look at closely, if you look at the distal end, you can actually see the toes. So the toes should be able to move freely at the end, making sure that nothing is sort of going over and where it's restricting the movement. You should be able to move them freely. These are for ankle fractures. Metatarsal, go past the toes to protect the toes. So you can see On the second picture, it comes up really high on the metatarsal, but on the first picture, on your left, it goes right down. So when you move them, the tendon doesn't dig in. So you can see it's nicely padded all the way around. It's soft, so it doesn't dig into the patient proximal and distal end. So that's your below knee cast. Again, make sure there's no wrinkles when you apply your cast, especially your synthetics. If you get a wrinkle, you can get a pressure area. So with any synthetic material that you apply, you're going to make sure it's nice, smooth. So looking at all the casts that you've seen on the slides, you're going to make sure they're nice and smooth. Once you've taken the cast off, there's a chance that you might need to put them in a cam walker, or initially put them right from the start in a cam walker. Cam walker, they're easily to fit, but you can also get them wrong. So you do really need to look at the instructions or get someone to explain to you how to fit them, because you can make a mistake. We have seen people and other clinicians where they haven't fitted them correctly, where they're too long at the toes, not the right size. Now, they are universal left and right, so you can put them on the left and you can put them on the right. Once again, you got 5 straps. So the secret to a cam walker is you pull it all apart, follow the instructions, put the padding on first, then fit your cam walker to the right size, and then apply the straps. How tight do you do the straps? That's the common question that I get asked from patients. Usually you do it as firm as they feel comfortable. If they're too tight, obviously you explain to the patient to loosen them. If they're too loose, tighten them. Make sure they're not restricting. Can you put on anything underneath like a sock? Yes, you can. Sometimes what we tend to do is when they are ORIF an ankle, we tend to put a stock in there and then put our cam walker. It also just protects the cam walker so they don't have to pull it apart and wash it again. So it's just one of these nice things that you can do for the patient if you choose to. That's entirely up to you. Or you can just put straight onto the limb. Again, the cam walker is designed as per you probably have better understanding if you're fitting it, or if you don't have any understanding, you should find out why we fit cam walkers and how they work and the biomechanics of it, so you can actually explain to the patient so they have better understanding. The more understanding the patient has, the better they'll look after and fit it correctly. So that's your cam walker. Again, we sometimes do it after a below knee, or sometimes initially we fit it straight ASAP when it's ORIFed, or it all depends on the surgeon. Again, he'll request that. So it's your cam walker. So we've pretty much covered the main common ones, which is the below elbow, scaphoid, colles, Smiths, and a below knee with cam walker, whether it's a wrist brace. Again, you can go into more depth in these things, but this is just a basic overall how you would do it, normal common cast. Thank you. I hope you enjoyed this video. Look forward to more presentations and to go into deeper and more things. Once again, thank you. I hope you enjoyed it.